Seema, how do you pronounce your last name? I don't want to. It's a seven. Is here watching us fumble through internet technology, but thankfully came up to join us and give the presentation. You can see in front of you here, eosinophilic esophagitis, pathogenesis, treatment, and endpoints. She gave a nice dinner talk last night that just led up to this presentation. But hopefully this will cover the basic science in much greater detail and therapy, which we didn't get into last night with a lot of advancements, a lot of tremendous changes in this. So please go ahead.
Well, it's a pleasure to be here. So if people on Zoom can't hear me, just I don't know, send a chat to somebody, so that we
You don't want to call me or tell me, but we had confirmation that the audio will work.
So I've got a lot of slides, so I will try not to fly through them. But I wanted to kind of cover a little bit of a lot, and so I'll try and give you a flavor of EOE from what causes it and how we treat it. And that will be great. There we go. My disclosures are listed here. The only one that's really relevant is that we came up with budesonide oral suspension, or eophilia, which is now FDA approved. But I'm not going to talk very much about that. So in 2018, we updated the EOE guidelines. So these are called the EGID guidelines. And what the biggest change in here was that you did not have to fail at PPI to get the diagnosis of eosinophilic esophagitis. So now PPI is considered one treatment option, and it's up to you. So this is a clinical pathologic diagnosis. It always has been. So you have to have a clinical presentation of esophageal dysfunction that will buy you the endoscopy. The endoscopy can but doesn't have to have features. There's nothing pathognomonic for EOE endoscopically, but it often does have abnormalities in it, such as you can see in this section over here. Oh, I'm sorry, the pointer doesn't seem to show up on the screen. Is it showing that? No. But anyway, panel A has a normal appearing esophagus with normal vascular markings, whereas B and C have a furrowed pale esophagus with these white plaques that are actually sheets of eosinophils if you look under the microscope, fixed concentric rings, and ultimately strictures with a friable esophagus. It's really easy to tear. So once you get that endoscopy with biopsy, you have to have at least 15 eosinophils per high power field to look the diagnosis. That's at any level, and you want to get multiple biopsies from multiple levels. Once you've ruled out that you don't think it's a secondary cause from something else, then you can diagnose the person with EO. So we have validated outcome metrics. So this disease was first reported in the literature in about the 1980s, like 1978, 1980. And I think we've come a really long way in a relatively short period of time. We now have a lot of validated tools, so we all can speak the same language. So there's a pediatric validated outcome questionnaire. It's called PEAS 2.0 is the one we have right now. It's a Likert scale. There's actually really good correlation between parents and children. So a parent reported outcome should be a good surrogate marker for what the kids are telling you. And then on the right side is the DSQ, or the dysphagia symptom questionnaire, that's used in many, many clinical trials. And it really asks about dysphagia. How much solid food could you eat? What did you have to do to remove it? So it asks about the impacts of dysphagia. There are also validated endoscopic scoring tools. This is called ERAS. It's validated in both kids and adults. Started out in adults, and it was developed at Northwestern. You can see it has what are considered inflammatory features endoscopically, and those are really the exudates, the furrows, and the edema. Although in some children, furrows can actually go with LP fibrosis or lamina-propria fibrosis, but classically it's considered an inflammatory feature. The remodeling feature, so if an endoscopist says this looks like a fibrostenotic esophagus, what they mean is that there are rings in there, or that there's a frank stricture in there, and that's pretty much the diagnosis of a fibrostenotic esophagus on the endoscopic front. There's also a validated histology scoring tool. It's called the HSS. It grades the severity, and so it stages and grades it. So it tells you how much of the esophagus is involved. It tells you how bad it is at any level that you look at. It correlates with features within itself quite well. The images on the left-hand side, that's the epithelium. It's hugely hyperplastic. And then the lamina propria becomes fibrotic, and that's a trichrome stain in there. And so it just looks like someone took a blue marker. It's not supposed to look like that. It's supposed to look like a nice, fine reticular network of collagen fibers, but it becomes very dense. There are also studies now, because everybody has a piece of epithelium when they get the biopsy, right? Because it's an endoluminal biopsy, it's very superficial. And so everyone has epithelium, but only about half the time during active disease do you have enough LP to gauge what's going on beneath that surface. And so Garesh Hiramath, who's at Vanderbilt, one of our junior trainees, junior faculty in our SEGR, which is our multidisciplinary network, multi-center multidisciplinary network, showed that certain features of the epithelium, specifically dyskeratotic epithelial cells, which is really a very rare finding, and basal zone hyperplasia, correlate really nicely with the presence of fibrosis. And you're looking at the receiver operator curve on the right hand side. So in theory, you could, and there's actually, it's cool, there's if you go to the paper, you can grab, there's a website, and you can pop in, if you get these features, you can pop them in and it generates you a probability that there's fibrosis or not. So it's a nice tool that he's created. So now the idea would be, well, if I just have epithelium, can I at least get a sense of whether this person is fibrotic or not, histologically fibrotic or not? So EOE is a chronic disease. This is does not seem to be something that you outgrow pretty much, even if you're a child, from what we understand today. I'd say nothing is 100%, but that's what it seems like right now. So this is a study on the left-hand side that was done by Alex Stroman a long time ago in 2003. These are adults that were followed for 7 years, and they have no intervention at all. And what you can see is the eosinophilia is persistent, but it does sort of start to burn itself out a little bit like normal airways. And the dysphagia is persistent. So if you don't treat it, it's not going to go away. If you stop treating it, it tends to come back. And so for every decade of life, you have an increase in your stricture rate of about 10%. And so you can see that this disease seems to pretty uniformly walk to stricture formation. And that's one of the things that we're really wanting to prevent. So I love this study. It was in Jackie in Practice a few years ago. It's David Hill and Jonathan Spergel's study, and they really posit that EOE is part of the allergic march, but it can fall in at any point in time. So you can see EOE is that flat red curve on the left-hand side, and you can see pretty much under any age it can show up. But if you're atopic, you're at a much higher risk for EOE. So the hazards ratio you can see in that little box is 9.1 if you have IgE mediated food allergies. And this is a very much atopic, male predominant 3-to-1 disease of children or adults. And right now it's largely in the white population, and it's not entirely clear if that's selection bias. There's some data now that shows that when you live far away from especially peds GI, that you miss the diagnosis because you don't have the access to care, you can't get there easily. And so some of that might be a selection bias. But from what we know right now, it's white predominant, male predominant, atopy predominant. And you can see on the graph on the far right that if you load up the number of allergic diatheses that you have, your hazards ratio for having EOE goes way up.
Does that 9.1 mean that we should see a lot of people who have both food anaphylaxis and EOE?
Yeah, especially in the pediatric population.
Do you see that in the real world?
Yes.
Okay. And then did you have an approximate incidence then?
A quarter.
Okay.
About a quarter of kids with EOE will have an IgE mediated food allergy. Many more than that will be sensitized to a food, right? You test them. They tend to have these low level serum IgEs in like the 2s, but they're making IgE to foods as part of who they are typically.
And how about the other way around? Among a highly allergic multi-diagnosis pediatric population,
How many have EOE?
does it, what percentage or what?
That I don't know, because you have to scope you have to scope everyone. So we'll talk about other ways to look at this disease, and I think that's where we're going to start to get a handle on it. So I'm going to shift over to the pathogenesis of the disease and tell you that this is a disease that seems to be a problem of barrier breakdown in the face of allergen, usually food, or air allergens can trigger it as well. drives this cytokine release and alarm response out of the epithelium that causes the influx of a number of inflammatory cells, eosinophils being the easiest to see and the ones that we count. That perpetuation of inflammation leads to the tissue remodeling that we see with fibrosis, smooth muscle hypertrophy, angiogenesis, and ultimately esophageal rigidity with stricture formation and food impactions. So the first thing I'll touch on, I'm kind of going to work my way from the outside through the wall of the esophagus. So is epithelial dysfunction. And this is a single cell sequencing study that was done by Mark Rothenberg's group. And what you can see is that it's clearly epithelial dysfunction. If you walk your way through the UMAP, which is basically how you display single cells and figure out who they are, then you look at just the epithelium. So you subcluster the epithelium. You can see that there are these different kinds of epithelial cells. So there are quiescent epithelial cells, proliferating, transitioning, and then of course the differentiated epithelium is a stratified squamous epithelium. So it develops from the bottom upwards. What you can see in homeostasis is that you have this nice sort of distribution. But if you look at the EOE esophagus on the far bottom left, you have a blockade of differentiation. So you get this very large accumulation of transitioning cells. You get a large accumulation of proliferating cells. And part of the problem is, although this arrow seems to point back, you'll see that it's sort of broken. And that's because a lot of times it doesn't completely normalize. And that's probably one of the reasons why this disease is ready to just rear its head again. So this is a really cool study. This was done by Pam Guerrero at the NIH, and this is a mouse model of Loeys-Dietz syndrome. So if you remember Loeys-Dietz connective tissue disorder, it's kind of in that same spectrum as Marfan syndrome. The kids tend to have IgE-mediated allergy. They're of course hypermobile, and they have a lot of other problems with their connective tissue, including vascular aneurysms. So she took the TGF-beta receptor 1 mutation that happens in kids that have Loeys-Dietz syndrome, and she put it into a mouse. So this is a knock-in of a mutation. And what she found was that there's not a lot of remodeling because there's not a lot of TGF that can't signal. None of the TGF-beta family members can signal. So there's not fibrosis, there's not smooth muscle hypertrophy. But what there is a lot of is there is a ton of epithelial proliferation. And super interestingly, she gets EOs, mast cells, T cells, ILC2s, antigen-presenting cells, but not a lot of B cells, neutrophils, NK, or basos. And what this really, to me, is it's a model of a mouse that is stuck in the inflammatory phase of the EOE. And so this is kind of what we consider in the EOE world to sort of be EOE endotype 2, which I'll get to in a little bit. But the other thing that's fascinating is there's a huge influx of ILC2. So TSLP is increased, and all of these ILC2s start infiltrating. They, of course, make boatloads of 4, 5, 13, in come your EOs, and off goes your pathogenesis. But probably the primary hit is the epithelial disruption. What's super interesting about her, oh, I didn't have it in here. What's really interesting about her epithelial disruption in this case is there's a lot of proliferation, no barrier dysfunction, by which I mean the electrical currents that you try and pass through are fine. And so there's something about this hyperplasia that is pathogenic for the esophagus. Foods can trigger EOE. This is an animal model just to show you that foods can be sufficient. This is an ova-driven mouse model. And this is work by Emily McGowan. And so Emily has been interested in IgG4. She trained with Tom Platts-Mills. And so she's been looking at the local deposition of IgG4. And what she finds is that IgG4 is present in the esophagus when you have active EOE, and it is bound to milk protein. So if she does this thing called STOMP, which is a way to look at proteins that are together with the IgG4, what she finds are LOSD4, D5, D8. So these are milk antigens that are together with the IgG4. Now the $1 million question is that pathogenic, or is it just something that you see? Because these patients don't have IgE mediated disease, they've got a T cell mediated disease, and they're making IgG4. And so is it pathogenic or is it not? You probably all know that there is an IgG4 fibrotic disease that's very rare and really an adult disease and does not histologically look anything like EOE. But
For one second, so we usually think of IgG4 as protective in an immune response.
Yeah.
That when you give immunotherapy, so
Not
how do you
here.
make that connect? Not here.
Not here. It could just be, if you're going to make IgE, then when you desensitize, which is kind of what the slide is about, if you desensitize, you make G4. Well, people with EOE aren't necessarily anaphylaxing, or at least not to the same food that's driving their EOE, or not to the same triggers that's driving their EOE. So they may be making G4 and going down a different pathway, and that might be bad for you. Or it could be a biomarker. I think we're still trying to figure. So this is on the left is a meta-analysis of OIT. The upshot is it can be up to 5%. Milk and egg drive it more. Peanut is very unlikely to drive it, but it can. The bottom line of what you need to remember is OIT can cause EOE. It's like in the page insert, it's technically a contraindication. Whether you follow that or not is a clinical question that we can talk about if you want to. But a lot of cases probably get missed because the biggest reason for stopping OIT is abdominal pain. And rather than having a scope, people often will stop their OIT. So the OIT induced EOE is really interesting. It might be transient. It could be that if you push through, it'll go away. It's often PPI responsive, and then there are a subgroup of patients where you stop what you think was the inciting trigger and the EOE sticks around. So you started this cascade in a person. So you have to have this conversation with your patients before you start them on OIT. They need to know that this is one of the risks. Slit can do this as well. So if it's, grass slit or desmite slit, we can do it as well. So this is aeroallergens and EOE. On the far left is a study by Jonathan Spergel from 2015, and you can see that during the pollen season to which the person is sensitized, you can find more esophageal eosinophils. So people have a flare of their EOE during the pollen season. So if you have somebody that's super ragweed allergic and you live on the East Coast, you might not want to scope them during their pollen season, because if you've got them, say, on a medication or an elimination diet, if they're flared, you're not going to know if it's because of the pollen or because your therapy that you chose isn't actually working. So that, that's a determination that you have to make and just be cognizant of it. And so when they go out of season, go straight. The middle image is an active EOE or remission or control esophagus. And that red stain is actually for house dust mite antigen. So what you can see is house dust mite is deposited directly into the esophagus. This is Dave Kotz's group. They've also shown that LPS is directly deposited in the esophagus. And it's loaded up with mast cells. So if you've got IgE dust mites, this probably isn't going to make your disease any easier to control. And that's exactly what Robbie Pesic and his group has seen in Arkansas, which is that if you have a where to point, but if you have a perennial aeroallergen allergy, it makes you less likely to respond to topical steroid or elimination diet. That person is just harder to treat, right? It's all a balance. The esophagus is trying to inflame and we're trying to stop it. And so sometimes the esophagus, wins. Early onset functional remodeling. This is very much like asthmatic airways. You guys know that. Airway remodeling starts very early in life, early as 6 years of age. Same thing in EOE. This is something called an endoflip. Endoflip is a volumetric, distendable balloon that's filled with saline, and it has impedance probes in it. And so what happens is you put the saline into the bag, you keep dilating that bag, you get a pressure read back from the esophagus. And when that happens, you can see how rigid it is. And so this is a measure of rigidity. I think of it as the closest thing to a PFT for EOE. It's unfortunately has to be done with an endoscopy, so you can't just do it whenever you wish to do it. But this is work by Amanda Muir. There's a lot of groups that have done it. Kalisman or Catcher in Colorado, we've had some studies on this. Josh Wexler's done a lot of nice work from Northwestern. Kids who are the gray bar that have EOE, they have rigidity of their esophagus down to the age of 3. So again, this is something that starts early in life, and you want to get a handle on it. Truly, like if you are a pediatric practitioner, this is your window of opportunity. Like you could potentially, if you control this disease, you can probably keep these people from walking the strictures. So I'm going to move to the pathogenesis, which is the part that I like to think about, which is the remodeling piece of thing. I'm going to talk to you a little bit about fibroblasts and a little bit about smooth muscle cell. So, but first I want you to understand what it is that we do in the lab, which is that we start with the esophagus. And that can be an active EOE esophagus, can be a remission esophagus, and then we get normal esophagus from organ donors. And so we've got transplant grade tissue. If it's a patient, of course, we take a biopsy, we disperse the biopsy to create cultured healthy or EOE fibroblasts. And then we use them in the culture dish to look at functional differences, differences in gene expression, like with volcano plots, differences in protein expression. And then we treat, especially healthy cells in vitro, and ask, depending on the treatment that we give you, do you act more like an EOE fibroblast? Do you become pathogenic? And so that's the model that we use for isolated cell culture. So there is a factor that's called light. It's in the TNF superfamily. It's called TNF-FS14. It's known to be involved in atopic dermatitis, psoriasis, asthma, and now in EOE. But if we treat a fibroblast as a normal fibroblast with TGF-beta, we turn it into a myofibroblast. That's not super surprising. That's just what happens with TGF. And you can see on the red heat map, all this stuff comes up. If you treat it with light, you turn it into a pro-inflammatory fibroblast. And there are all these different phenotypes of fibroblasts. Everyone used to think maybe still think they're boring stromal cells, but they're actually super plastic. They're kind of amazing. And that's why they are used to make iPSCs, right? All the stem cell cultures, the stuff that where you generate an iPSC, it all comes from a fibroblast because they're so plastic. So if you give a fibroblast light, you start to turn on complement 3, IL-32, ICAM1, TNF-SF13B, and that profile in that fibroblast looks very much like an inflammatory fibroblast from ulcerative colitis. And so you basically taken this fibroblast, turned it into something pro-inflammatory. And now if we take that fibroblast and we culture it and co-culture it with human eosinophils, we find that light-treated fibroblasts are pro-adherent for eosinophils. So what you see in the bottom, the top is a vehicle-treated fibroblast, the bottom is a light-treated fibroblast. And all those little black dots, those are all eosinophils, and they're all tethered onto the fibroblast. So if you're living in the stroma and you've got light coming out of a T cell, which the pathogenic effector T cell makes light, we've shown that on the single cell sequencing, when you've got this T cell making light, you're going to activate a fibroblast. That fibroblast is actually going to turn on ICAM1. ICAM1 is going to then tether the eosinophil, and now you've got a totally different kind of cell pulling eosinophils in. Remember that we think about the disease from the epithelial standpoint because that's what we can see as human beings, but the cells traffic from the blood and into the epithelial space, right? So they traverse the muscle and the lamina propria and break the basement membrane, and then they get to the epithelium. So they've got a trek to get there. And you can see these combinations of fibroblasts and eosinophils together in vivo. And if we use an ICAM blocking antibody, those eosinophil clusters fall apart. If we block the light receptors or take them away, goes away. So the other thing we were curious about is the proteome in the extracellular matrix. We wanted to know if the fibroblasts from EOE patients were different from a healthy fibroblasts in terms of what they were secreting into the matrix. So we took these fibroblasts from healthy people, we took them from active EOE patients, we decellularized the matrix, so there's no more cells left, it's just the collagen fibers and whatever else is laid down. And then we do what I call flip-flop experiments. So we swap the fibroblasts. We put a normal fibroblast back on its own ECM, or we put it on an EOE fibroblast-derived ECM. And then you can ask the question, is the ECM sufficient to change a normal, healthy fibroblast over? And it is. So we didn't see anything much on the transcript level, but if you look on the protein level, that normal healthy fibroblast now becomes a collagen producing myofibroblast, but it doesn't change fibronectin. That's like a housekeeping gene for a fibroblast almost. But it increases the amount of collagen and it increases the amount of smooth muscle. So the extracellular matrix that's deposited by a diseased EOE fibroblast is sufficient to convert a healthy fibroblast over to a collagen producing myofibroblast. Well, that's not really great, is it? So we have to figure out how to reverse these kinds of things. So then we did proteomics and we compared the extracellular matrix from a healthy fibroblast to the extracellular matrix from an EOE fibroblast in an unbiased way. What we found was that a thing called thrombospondin 1 seemed to be in the center of this protein-protein interaction network. And then we went back and said, okay, well, that's great, but it's only in a tissue culture plate. It doesn't really matter that much. So we went back and we stained biopsies, and there's a very significant increase in the number of TSP producing cells, both in the epithelium and the lamina propria. And then we said, okay, if we see these changes, can TSP1 drive that? And if you take a healthy or an EOE fibroblast and you treat it with TSP1, it starts to churn out more collagen. So TSP1 in the matrix is sufficient to drive the collagen production. It wasn't enough to make myofibroblasts. There's something else that seems to be doing that. But TSP1 actually cleaves latent TGF beta off of the extracellular matrix and allows it to function. And so this may be one mechanism that it's going through. And actually, if you block the TGF beta receptor, you get rid of it. This is a study by Policeman Catcher. And what she did was defined children as fibrostenotic or not endoscopically. So she looked down, and if they had rings or strictures, she called them fibrostenotic. And if they did, she called them non-fibrostenotic. They all have active EOE. Then she took those biopsies and she did what's called bulk RNA sequencing. So then she asked, what are the differences in the transcriptomic profiles, and are there any? And there are. Collagen 8A2, so the different deposited collagen, SMAD1, that's downstream of TGF beta family member transcription. And then she validated that. So the transcriptome of a patient that has EOE non-fibrostenosis is different from the transcriptome of a patient that has EOE but doesn't have fibrostenosis.
Can I just stop you for a second?
Yeah.
So is this leading up to the fact that this is not primarily an eosinophilic disease, but a fibroblast disease?
Well, so if you live in my world, absolutely.
Yeah.
I think if you live in most people's world, they will tell you, I think all of us would tell you now that the eosinophil is a good biomarker. It's easy to see on the stain. It does not seem to be pathogenic, or it does not seem to be exclusively pathogenic. It's not good to have degranulated eosinophils. They make tons of RNases. They break down epithelium, and we'll get to that. But yeah, the eosinophil is definitely not the entire player in this disease, even though we use it to diagnose it. So the other thing we're interested in is smooth muscle and how is that functioning. This is manometry, which is a super uncomfortable procedure. But what it shows you is that there's an intersection between rigidity of the esophagus and dysfunction of the smooth muscle. And that really red area, that is just a sip of water. And this person's esophagus is contracting like mad, trying to get this water bolus down, which of course should just slide down on its own. If you do an ultrasound of the esophagus, what you can see is the EOE esophagus has transmural thickening all the way through the muscle wall. And Margaret Collins, who developed the HSS, has looked at non-EOE strictures in children who have had like a full thickness resection. And what she sees is all of this brown stain, that's all smooth muscle, and it's invading entirely through the LP, and now it's actually abutting the epithelium where it should not be living there, and so there's clearly this hypertrophy and maybe even hyperplasia of the muscle. So we wanted to experimentally mimic a rigid esophagus, and we do that by using bioengineered substrates. So these are plates that are made with silicone matrix that you then coat with collagen to make the cells stick. But it's of a known Young's modulus or a known KPA. A normal esophagus is actually really gelatinous and soft. And its normal KPA is probably more in the range of 2 or 0.3. That's a very soft surface. But then if you have a rigid surface, which is 32 kPa, so just to put this in perspective, bone is way harder than this. It's 900 kPa, and a piece of plastic is in the gig kPa ranges, the gig kPa ranges. So it's much harder, but it's still relatively compared to a usual tissue culture plate or compared to bone. And then we stained for a protein called phospholamban because historically we've seen that TGF beta upregulates this protein. This is a protein that lives in the sarcoplasmic reticulum, which is the endoplasmic reticulum of a muscle cell, and it regulates calcium flux, and it's absolutely necessary for proper cardiac contractility. If you have mutations in PLN, you have cardiomyopathy, and you will end up with a heart transplant. So this is very important for proper contractility of muscles, and it turns out that TGF beta turns it on. It turns out that rigid matrix really turns it on, so it makes the cells hypertrophic, and you can see that green stain is for PLN. If you do flow, you can see that the cells on a rigid matrix are a lot bigger than the cells on a smaller matrix. So the higher that number means cells are bigger on flow. So I'm going to walk you through this because it's a little bit complicated, but it's actually super cool. So PLN induces smooth muscle hypertrophy. So if we take a normal smooth muscle cell, we make it transgenic for PLN. We turn on the PLN with a DOX, inducible promoter, those cells get bigger on flow. That's the histogram with the shift. Now, if you put those cells on soft matrix, the ones that I showed you over here should be, it should be thin and small. You put them on a soft matrix, you give them PLN, it now bypasses the necessity for a soft matrix. So even on a soft matrix, those cells become too big. And then we stained biopsies, because again, if it only happens in a culture dish, it doesn't really matter. And so we asked, okay, there's this protein that's well known in the literature. It's called YAP1. It's involved in a lot of processes, but one of the things it's known to do is work through a pathway called HIPPO, and that pathway makes tissues bigger and it makes muscle bigger. And we asked, okay, if you have EOE, do you have YAP in your nucleus? It's a co-activator, and so it changes gene transcription. We said, if you have EOE, do you have YAP in your nucleus? Are you kind of primed to have bigger, smooth muscle cells? And the answer is yes. So if you have active EOE, you have more nuclear YAP positive cells in your smooth muscle bundle. That's what the stain is looking at. So then we said, okay, well, PLN makes cells bigger and it responds to rigid matrix. That's called mechanotransduction. A mechanical physical signal is being transmitted through the cell to change its function. And we said, okay, well, we know PLN goes up when you put the cell on a rigid matrix. We know that YAP historically makes things bigger, and it's known to translocate into the nucleus when it's on a rigid substrate. So is PLN actually working in some mechanotransductive pathway? So we asked two questions. What happens to PLN if you take YAP out of a muscle cell? And what happens to YAP if you give too much PLN to a muscle cell? So it turns out that if you take YAP away, PLN no longer can turn on a soft matrix. And so that's what this graph is showing you. If you knock out YAP with something called an shRNA, which blocks the transcription of YAP, now what happens is those cells on a rigid matrix no longer get hard. So you can take away YAP and you can make those cells not get too big. And then if you do the opposite experiment where you give too much PLN on a soft matrix, you actually bypass what I had shown you before, those cells become big, and it turns out that the way it bypasses is to increase nuclear YAP. So on a soft matrix, you give PLN and it shoots YAP into the nucleus, and it turns out that it traps it there. And the way it traps it there is by changing the actin cytoskeleton. So here's this thing that sits in the sarcoplasmic reticulum. It goes up when you give, when you change the rigidity of the matrix. That process turns on the actin cytoskeleton genes. That's what's being shown in the volcano plot. The actin cytoskeleton is actually, it's more stable. So if you give something called latrunculin A, which destabilizes actin fibers, when you have PLN, that's this bottom corner graph, you can still see those stress fibers as compared to up above, which is where they've broken down. So what happens, so then the question becomes, okay, if I make the matrix soft again, can I like reverse this whole process? Like if I could rigidify the esophagus of a patient with EOE, could I make the muscle cells normal again? And that's what this is showing you. If you culture the cell on a rigid matrix and then you shift them over to a soft matrix, what happens is they actually get smaller again. So the nuclear YAP goes down, the PLN transcription goes down, and most importantly, the size of the muscle cell comes down. And so the rigid matrix alone, inside of inflammatory signals, is enough to make the smooth muscle too big. I didn't show you the data, but it also changes the way it contracts. And it does that by turning on PLN, or at least one way it does it, is by turning on PLN, stabilizing the actin cytoskeleton, trapping YAP into the nucleus, and now you've got this cascade for hypertrophy. So that's what this is telling you. So rigid matrix turns on YAP, turns on PLN in this forward feed loop that turns a healthy esophagus, we think, into a more hypertrophic EOE esophagus. Okay, so all of that to tell you some of the mechanisms that drive this to be a chronic disease, right? Because you've got these feed forward loops, right? How many times were you taught, hopefully as a question or a fellow, inflammation begets more inflammation. You have to stop that cascade. If you got inflammation, it's just going to keep bringing in more friends. That's what it does. And so when you have fibrosis, it keeps on revving up more fibrosis. If you have muscle hypertrophy, that revs rigidity, that revs muscle hypertrophy. So you got to break this loop somehow, right? So this is this pathway that we think what happens is you walk from an inflammatory esophagus to a more fibrous stenotic esophagus. And so how do we stop this? This is a fun study. It was just published in JACI. It took all of the publicly available RNA bulk sequencing data and it put it together. And when this group, this was at Vanderbilt, when this group had enough patients because they put all this computational and we combined all this RNA sequencing data, then they had big enough numbers to compare kids to adults and ask if there were transcriptomic differences between children and adults. And what they found was that there were quite a few transcriptomic differences, and kids tended to be more mast cell rich, and adults tended to be more macrophage rich. And so that to me is really interesting. If you want a little synopsis, one of my computational collaborators and I wrote a little editorial, so it'll like summarize it for you in a bite-sized piece. But the other thing they found was that the predicted pathways were really different. So in kids, it was acute phase responses, IL-10 signaling, icosanoid signaling, antioxidant. So IL-10 and antioxidants, we would think of that as sort of protective. So it seems like kids still have this mechanism to try and protect their esophagus. But then if you look at the predicted pathway, so that doesn't mean they're absolutely happening, but it's what's predicted by the RNA sequencing. In adults, it's much more IL-6, STAT3, myogenesis, fibrosis, hepatic fibrosis. So all these things that look like fibrotic cascades. What I want to point out to you is that this is a T2 inflammatory disease. However, there's a lot of innate immunity going on, both kids and adults. So on the right side, the overlapping circles mean the pathways are common in children and adults. When the circles are apart or there's only one circle, it means either they're completely different, partially different in adults and kids. So what you can see here is inflammatory response, of course, is very high, but interferon gamma and alpha responses are very high as well. So there is this innate immune pathway going on, in addition to the type 2 inflammation that we see. Okay, so how about, I told you this is a disease where we scope over and over again, but you're an allergist and we're all allergists, I'm assuming, and you don't have access to GI very easily. It happens a lot, especially in the adult world, especially outside of academic centers. It can be hard to get your patients scoped over and over again. So how else can you look at the esophagus? Well, the great thing is now that there's 2 ways that you can utilize to look at the esophagus, and you don't need to have scope to do this. One is called a side sponge. I don't do it in kids. It's very much of an adult procedure, though anyone adult could do it. And something called the esophageal string test, and that can be done in children or adults. So the side sponge is literally a capsule, has sponge inside of it. You drop it down the esophagus, the capsule melts, the sponge comes out, and when you pull that sponge back out, you get a chunk of esophagus. Now, the sponge can come off of the string from what I hear. Now you've got an impaction. So you do need to have a GI person around if you're going to do this. But if you want to talk to somebody that does this, Emily McGowan does this at UVA. She's an adult person. I don't do this. But it has really good sensitivity and specificity in terms of finding EOs on that sponge as compared to a biopsy. So you don't need a biopsy to do this. Now, if you do this, you have to be really sure that you don't have a strictured person, right? Because you don't want to get something stuck down there. So this is not for diagnosing, but it can be really helpful for figuring out what's going on if you institute a therapy and you just can't get another biopsy. This is the esophageal string test. This was developed in Colorado by Glenn Ferruda and Steve Ackerman, who's in Chicago. What you can see is that the esophageal string test, it works after an hour. You can see inflammatory products from the eosinophils. Patients really like it. And the last thing is transnasal endoscopy. This is usually done by a GI doc, but it doesn't require anesthesia. It's topical lidocaine. It basically is like an NG tube with camera on the end. It goes down the esophagus. You can get biopsies and you can actually look at the esophagus. You can't dilate it. But the EST is a 1-hour procedure. It's a 99215 billing code, and it is a billable procedure, and you can do it in your office. And if you want to know who sells it, I can give you the information. It's something called EnroTrack. I'm trying to get it set up in our clinic. Other people are doing it. And it is a capsule it's the old Giardia test. So it's a capsule with a string loaded inside. You swallow the capsule, you take the string to the cheek. The capsule falls down. It's a weighted capsule, so it stops in the stomach. The capsule dissolves. Remember, the esophagus is usually this collapsible tube, right? So the string goes up against the esophagus. You leave it there for an hour. You pull it out. You send it off for eosinophil products. And that's it. And it has to go on dry ice. That's probably the most painful part of it is that you have to get it to your lab and have it shipped on dry ice. We do that for like an AH-52, so the lab should be able to do that. So I'm in the process of getting it started. I'll let you know how it goes. But this, the repeat endoscopies is where you sometimes lose your patients because they don't want to have another scope, but they probably are willing to come into your office for an hour, and you can at least say, it looks like your disease is under pretty good control, or it looks like, you still got active inflammation. So really, I really think as allergists, like this is our disease too. This is not just a GI disease. Like just because you need a scope, I mean, you don't always need a pulmonologist to help you take care of an asthma patient, right? You don't always need a dermatologist to help you take care of an atopic dermatitis patient. It's nice when you do, but I think you need to consider this your disease. These people are atopic. They've got multiple atopy. They've got dust mite allergy. If you wouldn't let your asthmatic go sleep in a dust mite infested bed, which I'm assuming you all know the study from 1980s from Tom Platts Mills, right? Steroid dependent asthmatics come off of oral steroids if you put them in a dust mite free area. If they're allergic to dust mite, I'm not going to let my EOE patients sleep in a dust mite infested bed either. I always do aeroallergen testing, and they don't tend to always have a lot of allergic rhinitis symptoms, so I'll make them do avoidance if nothing else. And I just explain to the families, everything you inhale, you swallow a little bit of, and I just want to stack the cards in your favor, and it's what you should do.
With the sponge, I mean,
Yeah.
you just get the surface epithelium.
Correct. And so in the string, you don't even get cells. You just get the products from the eosinophil.
Oh, really? So like you're measuring ECP
You're
and
measuring, eotaxin, ECP, EDN. Yeah. But they initially did it as an overnight test, and they correlated that with the endoscopy and showed that it correlates. Now they've done the same thing with the 1 hour test, and it shows that it coordinates. So not perfect. And again, I think people need an endoscopy, but sometimes it's not realistic that they're going to get, or they can't get one in the time frame that you need one because of the scheduling issues that come up. So this is EndoFlip. I'm probably just going to skip this slide because I already told you everything on it. This is a really neat study that just came out in HAG from Amanda Meyers' group. She worked with the feeding team, and they did a study where they had children eat different textures of food and looked at how long it took them to finish their meal, and correlated that to inflammation, to which it didn't correlate very well to eosinophils. What it did correlate to beautifully was distensibility. So the longer the consumption time, the lower the distensibility of the child's esophagus. So ask your pediatric patients and even your adults, how long does it take you to finish a meal? Because my parents will often tell me, oh yeah, that's the last kid at the table. Has been that way their whole life. Like that's the kid that doesn't finish a meal in a timely fashion. And this is probably why they probably have remodeling in there. And sometimes it becomes a battle, and you have to make the parents feel less guilty about the fact, because a lot of them have come in and say, oh my gosh, like I thought they were just being stubborn, and now like it turns out they have this horrible inflammation, and you have to say like, well, it's not your fault. You wouldn't know. It's okay, but now you know. So if it's taking them a long time to eat, like that's just the way they are. So give them a little time, and hopefully it will change. It's very hard to change behaviors in children, so that's not necessarily an easy thing. A lot of us are looking for surrogate markers so that everyone doesn't have to get a flip, because that's definitely not realistic. Everyone is not going to get a flip. Catheters are expensive. It adds time to the endoscopy. So Pi1 is the same thing as Serpin E1. It's plasminogen activator inhibitor 1. It's a serine protease inhibitor. And it goes up when you have EOE, and you can just stain for it in the epithelium. That's that red stain. If you have low compliance, so less distensibility, you have more Pi1 in the epithelium. And if you combine Pi1 and basal zone hyperplasia, you can see the receiver operator curve is pretty good for predicting in children with EOE having a low compliance. So I think we'll get to the point where we have sort of less invasive, like not have to have a flip to gauge their compliance, because that's a special thing. to do. And then Josh Wexler has really shown that when you have, if you look at just a little graph up top, when you look at the flip results in a child, when you have fibrostenotic features, the flip is very low. If you have inflammatory features, it's less low, the distensibility. And if you have a normal endoscopy, then you have pretty good distensibility of the esophagus. And then that can predict out food interactions. All right, so now I've told you it's chronic, this is how it happens, this is what we know. Patients have symptoms, what are you gonna treat? What's your endpoint? Symptoms, inflammation, remodeling, you're gonna treat them forever, you're gonna treat them short term, these are the decisions that you have to make. So there's a new tool, if you want this, it's on an app now. It's called IC, and it grades the severity of EOE on multiple features, not just eosinophils. So what we did was we tried to build it so there looked at symptoms, complications of symptoms like poor growth, inflammatory features, and then fibrostenotic features histologically and endoscopically. So it's called AGA-IC. If you go to the App Store, you can download it. It's really easy to use. The kicker is you have to have all the features, and we're in the process. The AGA developed this, and we've taken it out for beta testing to allergists and GI doctors to see if it's usable, and more importantly, what information do you have? Like, what is your pathologist telling you, and what is in your endoscopy report? Okay, so finally, what Len's been waiting for, talk about therapies to bring EOE into remission. So 3 possible therapies, 4 actually. PPIs, elimination diet, topical corticosteroid, dupilumab. Those are your options right now. Combinations thereof. Proton pump inhibitors, 42% response overall. Rarely my first choice, because it's systemic. It buys you an extra scope to find out that you still have EOE. Only about 30% in kids. Much better in adults, can be as high as 70% effective in adults for reasons that we don't understand, except that we do know, oh, this is what I was looking for, but it doesn't matter anymore. That's the TGF-beta mouse that doesn't have barrier dysfunction, even though they've got hyperplasia. What we do know is when you push the dose of PPI, so we use it twice a day in kids at a dose of 1 milligram per kilogram per dose, so 2 mg per kilo per day. So you're talking like 40 BID of omeprazole in an adult. You're talking about good high dose PPI, way beyond acid blocking effects. And it turns out that it changes the actual transcriptome and the biologic processes that are happening in the epithelial cells, and it seems to decrease their stress response, it decreases their cytoskeleton, and so they become more normal in the face of this high dose PPI, and that's probably how it's really working. So things that people worry about, first of all, no longer have to have it. People worry about systemic side effects. They're known to leach calcium out of the bones. Does that happen in children? It's clear. May not want to use it long term. And you can lose therapeutic benefit when you use it long term. And the patients that tend to lose therapeutic benefit of long term PPI, at least over a year, are patients that have allergic rhinitis and a change in the STAT6 gene, which I'll show you later. So eliminating food allergens. The upshot, it can be, this is a meta-analysis with 68% response. Milk, egg, wheat, soy, we know that 4 food elimination is just as good as 6 food elimination. Don't bother with the peanuts, tree nuts, fish, and shellfish. It's just going to buy you more endoscopies than most people. A step-up elimination diet is perfectly reasonable. Start with milk and then move on if that doesn't work. So milk only, if that doesn't work, go to milk, egg. I'm sorry, go to milk, egg, wheat, soy. You can step up your diet elimination. I'm gonna grab something to drink. So targeting elimination.
While you stop for a second, often I'll tell people just to start with meat and milk is the 2.
Perfectly reasonable. Really good. We don't have data on milk and wheat elimination only, but we do have data on milk alone, and that's what this study is showing you. This was just published recently. Sorry. This was published in the Lancet GI. This is a multi-center study that we did through Seeger. This was before we knew about 4 food elimination diets. So this is 6 food versus milk. The upshot is, it doesn't make any difference. You don't get a whole lot more bang for your buck by avoiding more foods beyond milk. You do get, less eosinophils, but it's not clear that that really matters. Symptoms were basically the same for the patient. So starting with just milk is very reasonable. The other thing that we found a little shocking was it was 40% response. It wasn't it wasn't the 68-70% response that you see in single center studies. And we had dietitians, we did education, and it was still only about 40%. So what to eliminate, and don't bother testing, prick testing alone is not useful. We can talk about whether you want to do that or not. I use it backwards for loss of tolerance to cow's milk, especially. But prick and patch testing in kids can be helpful if you combine it with prick, but it's not better than empiric elimination diet. The patch testing is really, really labor intensive. So this is just an approach to reintroducing foods. We usually start with the least allergenic and move our way up the chain, but it's really a conversation with your patient about what they would like, what do they miss the most? What do they want to use? What they want back in your diet? And again, I test for milk, egg, wheat, and soy in everybody, and that's because if they decide to do an elimination diet, I want to know if they've got a really big test or high serum IgE, especially to milk, because I'll usually do an oral food challenge if they've been avoiding it for a while, just to make sure. I'm not sure that's really needed with adults. I don't tend to give out EpiPens, even if you have sensitization, you're doing a diet. Right. Topical corticosteroids, this is the meta-analysis, upshot, better to use it, CCS than nothing. This is budesonide oral dispersible tablet. This is approved in Europe. And you can see it works well, it gets rid of histology, gets rid of endoscopy abnormalities, and then it helps with symptoms. So this dosing was 1 milligram twice a day, far superior to placebo. This is budesonide oral suspension, which is now approved in the US for 11 and over. Again, have a good profile in terms of histologic changes. Kind of minimal in terms of dysphagia. It is statistically significant, but patients still continue to have dysphagia. This is a higher dosing. This is 2 milligrams BID is what they used in the clinical trials. So potential approaches, give it to 6 to 12 weeks. You can, talk the budesonide viscous your own way. You can see if you can get it covered by insurance. You can use a fluticasone inhaler. That's getting hard now that Flovent is off the market, but you can usually get the generic. Side effects, patients will always ask you about side effects. It doesn't seem to affect growth. It goes through first pass metabolism when you swallow it. So the studies right now don't show that it has any effect on growth. In fact, the kids grow better because they eat more. So they're usually getting more weight on and they're getting taller. So just the opposite of what you might predict. PPIs plus minus mental formulas and elimination diets can be associated with low bone mineral density. I do tend to get DEXAs if I'm using PPI long-term in the kids. Laboratory adrenal suppression does happen. Clinical adrenal suppression with crisis is really rare. There's a couple of case reports with the topical steroids to the esophagus. Mepolizumab, this gets to your question. It gets rid of the eosinophils, but it doesn't do anything to the symptoms and doesn't make a huge difference on the endoscopy. It helps. But this study did not meet its primary endpoint, which was really like, is it better if you add it on to a topical steroid? And it doesn't seem that targeting the EO alone is good enough. This is the dupilumab study published in New England Journal of Medicine. This is the adult study, and the PED study led to its approval down to the age of 1. This works great. So dupilumab works great. It was the first thing that was approved, and it's up to you to decide because the FDA gave you no guidance because there was nothing else that was approved. So dupilumab is available for EOE, and then the question becomes, do you want to use it? Who are you going to use it in? How long are you going to use it? Lots of new things coming down the pipeline. I'm going to skip this slide. So this is the management algorithm. You treat, you see if it's better, and then you change your management or you go on a maintenance dose. That's pretty much it. Treatment does help. IC drops in adults. This is the proton pump inhibitor data. If you have a mutation or a SNP in the STAT6 promoter, then or the 6 gene, that can change your long-term response to a PPI. Budesonide oral dispersible tablet, the European dissolving tablet works long-term as well. You can use it at 1 milligram or 5 milligram twice a day. Elimination diets also work long-term until you put the wrong food back in, and then the disease will come back again. And these are children, and only 15% of them are non-responders. 85% of them will respond to something that you do. This is all comers in our cohorts. Topical steroids, it's PPIs, it's elimination diet. This was before dupilumab was used, so no one on Dupi. What's interesting is the histologic response rate in males, in adults and kids is 85%, and it's that 15% of non-responders that go on to have food impactions or strictures, and that's true in children in our center, and it's true in adults in the Swiss cohort. Interestingly, female sex is a predictive index for deep remission. And when you look at our kids, the graph on the left-hand side, if you look at the continuous or responders, 90% of them have an initial response to therapy, and the male-female ratio is 1-to-1. But when you get to the non-responders, the initial response is only 14%, and the male-female ratio is 6-to-1. So way more boys are non-responding to therapies that we try than girls are, not clear why. It also helps with the long-term histologic remodeling. This is topical steroids long-term. And this is just a box that tells you that patients aren't having food impactions nearly as often. And the IC drops. But in kids, when you're looking at the things that are more difficult to treat, like the malnutrition that's leading to their poor growth, or their total IC score takes longer. So their first endoscopy, it's usually better, but not like the malnutrition isn't better by the second. The last endoscopy is when, for the total IC and the malnutrition, you can see those things drop. So if you want to get rid of LP fibrosis, you want to get rid of, an eating habit, that takes time. That last endoscopy in our cohort could be the third endoscopy, it could be like a year later, it could be 13 years later. That's how long these kids have been followed up for. So it takes time, but you will get there. So follow-up, that's the most important thing you're going to do for your patient. Risk of strictures goes up when you don't have close follow-up. In this study, that was a loss to follow-up for 2 years or more. And we definitely saw this during the pandemic, where people were going off of their therapy and then coming back. And our other adolescents were coming back with strictures or really bad EOE after being off their therapy. So it does predispose you. So this is my last slide. So the conclusions are really consider your therapeutic target. Are you going to treat long-term, short-term? I would say you need to treat long-term. And then what's your end game? Is it the inflammation? Is it the remodeling? It will change kind of how you think about this person. Chronic disease, you have to talk to your patient. What do they want to do? What's realistic for them? Can they actually eliminate a bunch of foods, or is that too hard for them? Are they already avoiding milk because they anaphylaxis to it? Well, then that's not your trigger, right? It's something else that's triggering your EOE. Think about your patient preference, their weight, their age, the approved therapy, and whether they have concurrent atopy. If you have a patient that has like moderate to severe asthma, and they've got EOE, maybe you want to give them DP. Maybe you can hit 2 birds with that single, biologic. So maybe you want to think about that. You've got a kid with really severe atopic dermatitis and EOE. That's a good person to think about having DP for. The current literature shows that DP does seem to help, even in a stricter patient. That's important because that's the person that was banned from the EOE trial because their disease was too severe. It's just like anaphylaxis. You're barred from the trial if you have really severe anaphylaxis because nobody wants to give you that food to prove that you're allergic. If you have a stricture, then that's the exclusion criteria. Severe stricture is an exclusion criteria in most of the trials. So I'm going to stop there. I've left a little, like 2 minutes for questions. Sorry. But I'm happy to answer anything you have, and you can always email me. But thanks to Len for inviting me. And this is everybody in my lab that does all the work, so I get to travel around and tell them about things.
Could you repeat that? I'm joking.
The whole thing? Oh my God. Yeah, I'm just thinking my slide deck. It's sitting on this computer.
I got the impression from your basic science that this is primarily a fibroblast smooth muscle disease, and that eosinophils get trapped. And we monitor it because that's something we can count. Is that what you're trying to tell us?
I think, it's very much like asthma. I think it is a disease of epithelial barrier dysfunction. So people who have low EDs develop EOE outside of a, clear antigen, like they just develop it. People with a SPINK mutation can just develop it, but these monogenic causes of EOE are very rare, and you always have a bunch of other stuff going on. But it seems like probably the primary hit is epithelial disruption, and that could even be from acid, right? And then you're an atopic person. I think of EOE as wound healing. So you're going to try and fix the problem, right? Nobody's trying to give themselves EOE. They're trying to fix the problem. But if you're atopic, you're going to send out an alarming response with IL-33 and TSLP. And I didn't show you all of that, but those are the things that then will call in the ILC2s. And I also didn't show you, but there are pathogenic effector T cells in the esophagus that make IL-4 and 13 and can be responsive to milk in vitro, which hopefully will eventually become like a blood test for predicting who might do well with a milk-only elimination diet. So I'd say it's a disease of epithelial barrier disruption that calls in inflammation that travels through, the LP, probably leaving, as you say, cytokines and junk behind that gets trapped in that fibrotic LP that then revs on itself. And so you gotta break it early. If it's early in the disease or you're a child, if you control the inflammation, you usually control the fibrosis underneath the surface. And those people usually don't walk on to having it stricture. So, you want to hit it early so that you can control that barrier. But if you can get your pathologist to tell you about things like basal zone hyperplasia, it's often still there, even post-therapy. And a remission fibroblast, so I didn't show you any of this data, and we actually haven't published any of it yet. But a remission fibroblast does not act like a healthy fibroblast, right? So if you give factors to these, it's very interesting. For the most part, what you see is that if you give a factor, be it TGF, be it light, that EOE active fibroblast responds the least, as if it's burnt out and tired. The remission fibroblast responds a little bit better, and the healthy fibroblast flies in terms of gene transcript at what you're looking at might be pathogenic. So remission for the epithelium is probably not the same as health, and remission for the fibroblast is probably not the same as health. So you've got this probably epigenetic memory in these structural cells, and they're just sitting there primed. And that doesn't even talk about, we really don't even understand the resident T cell or, whoever else has that memory. The poor esophagus wasn't meant to be an immune organ, right? It's just supposed to be a tube. It's just supposed to push the food down. And now it's gotten all inflamed and it doesn't know what to do.
So it sounds like asthma, we can't cure this disease, you have to treat this indefinitely.
Yeah, and unlike asthma, where some kids will grow, right, those early wheezers where it's virally induced and they're non-atopic, that wheezer grows out of their asthma, right? We haven't found that phenotype yet for EOE. I'm not saying it doesn't exist, because I suspect it does, and I think it probably, is maybe a younger or a shorter duration, and it's probably not something that I see at an academic, tertiary academic center, but I wouldn't. It's very disheartening to patients to hear like, oh yeah, this is never going to go away, but that is what I tell them. Like, more likely than not, you're going to need to do something your whole life. That something can change. You don't have to take a steroid forever. You don't have to do an elimination diet forever. And I think really from an allergist standpoint, do you have to do DP forever? That's a different conversation, but I think that you have to be cognizant of what you choose and have a conversation with your families about what is realistic for them and what are you really going to do. There were a couple of questions in the chat.
Oh, wait.
Something in the chat.
My question was to do with, have you noticed any change with early introduction guidelines in the infants and toddlers? Like FIs now, they have peanut FIs and everything else.
I think that is such a good question. We don't know yet. The early introduction too has focused largely on peanut, which is not a huge driver of EOE. But I don't know the answer. The early life studies show PPI use in early life, but it's not clear that, is that just the baby that has EOE and was a spitty baby, so somebody gave them a PPI, or the PPI actually pathogenic and causing a change in the breakdown of foods or whatever, right? Because there's a whole literature on PPI and tube digestion, and it may make foods more antigenic. So I think that part's not clear. I don't know the answer to that. I think we're going to find the answer to that. And that's one of the things that kind of worries me about long-term DP with no guidance from the FDA. I don't know. If you ask me, my choice, what kind of inflammation are you going to choose? take T2 any day of the week. I don't want TH17. I don't want, I don't want an 8. I don't want arthritis, I also don't want EOE, but T2 inflammation, relatively speaking, is relatively benign in that it's like a long brew.
Live with it.
It's not, it's not ulcerative colitis. You're not going to get colon cancer. You don't need a colectomy. So, and there are signals in the dupilumab literature, and I've seen it in the trials. People show up with psoriasis, arthritis. So for some, the immune system's like a jack, right? And for some people, you toggle it and you twitch it, and they tip the other direction. And other people are never going to do that. We just don't know who's who. So I think that's the one thing, like, just to be cognizant about. And it doesn't mean it's not going to go away when you stop the drug. Like, it doesn't mean it's a permanent thing, but I do tell my patients, if you have a new rash, send me a picture. Like, I want to know that you're not developing psoriasis. I had a kid in the DP clinical trial. I knew exactly what he was on. He got placebo first and he got DP second because his EOE went away and his psoriasis flared like crazy. Psoriasis that he didn't even have since the time that he was a little kid. But so that wasn't the right choice for him. So I do warn people about this whole immune dysregulation that we're basically inducing, right?
Yeah.
Somebody has in the chat, Lauren has in the chat, saying the GI team ordered tryptase levels in pediatric EOE patients, which have not found helpful. Yeah. So it's not helpful. I guess that's the quickest answer. It's not helpful. It's not going to help you manage your therapy. There are patients that have like mast cell activation syndrome, connective tissue, EDS. You're all laughing. It's like your favorite patient, right? The trunks that also has EOE. And so in that person, a tryptase might be useful, but generally it's not going to help you manage EOE. It's not been shown to be a good marker. Actually, the best peripheral marker in the literature are eosinophils, peripheral eosinophilia. But because people are multiply atopic, you don't know where they're going. And that's really the problem. I guess that's the direct message to me. Jay Springer asked, what's the message of the day? What's the word of the day?
The word of the day, do you know what it is? That people use that to get CME credit.
Does anyone know what it is? Is it in the chat?
Somebody, but nobody in this room seems to know. I don't know.
Is it on the invitation?
It's on the invitation.
Look up the invitation.
They say look on the invitation for the word of the day, so you can get your CME credit.
Well, thank you so much.